Good morning. That introduction made me sound a lot cooler than I really am. I just wanted to thank you guys for having me here today. It's a real honor to come and talk. I love lecturing. I love educating people on what it is we do and the kind of services that not just me, but physical therapists across the country can offer. I am blessed to have parents that are here today. My parents, Greg and Gail, are over here. You guys want to stand up? Give them a hand. They've been putting up with me for 36 very long years. They deserve an award for that. But yeah, so Tina, thank you for the introduction. As stated, I do run a clinic in Woodbridge called Fusion Physical Therapy and Cardiac Rehabilitation. It's owned by Woodbridge Physical Therapy. And this last fall, I decided I wanted to branch out and really start owning my own clinic. So I opened up a clinic down in Spotsylvania, right across from the HRC, in a Centaura Pratt Medical Building. So right now, I'm kind of working 2 jobs, and I'm working a whole lot, and I'm loving every second of it. I really am. It's a labor of love. So there's all my credential things. I also lab assist for Maitland Australian physiotherapy seminars, so I actually go all up and down the East Coast and help teach other therapists how to treat patients. A different way of thinking and a different way of doing things. I learned vestibular rehabilitation at Valley Health System in Winchester, Virginia. I worked there for about 3.5 years, and I was trained in vestibular rehabilitation at the Rehab Institute of Chicago. So, that's a whole lot. Now, I get referrals for vertigo all the time, and some people call vertigo just losing balance. Some people say it's the room spinning. Some people just feel a little wavy like they got off a boat. Some people say it's blurred vision. Some people say it's lightheadedness. The bottom line is we all kind of define vertigo in our own separate way. Some people are like, oh no, it's not vertigo, it's decreased balance, or it's not vertigo, I just feel lightheaded. And that's fine. But it's really just all vertigo. It's just how we choose to define it as an individual. Specifically defined, vertigo is a sensation of whirling and loss of balance associated particularly with looking down from a great height or caused by disease affecting the inner ear or vestibular nerve. And then there's giddiness, which if we all have a few too many cocktails, we all start getting vertigo, right? So, the bottom line is, you're right. However you're choosing to define vertigo is exactly how you define it, because it's all-encompassing. Now, there are several different causes of vertigo. Central vertigo, which has to do with the brain and spinal cord. And those are people that have had traumatic brain injuries, strokes, anything along those lines. Sometimes people with Parkinson's, MS, they can also be experiencing vertigo. And that's all from a central orient, from the central nervous system. There's pathological vertigo. Now, pathological vertigo is if you have some type of actual ototoxic disease. Some people have had gentamicin toxicity. Gentamicin is an antibiotic very commonly prescribed in the hospital. It's usually IV. The problem is, and I'm going to get into the inner workings of the vestibular system here in a minute, but they can actually destroy the inner workings of your inner ear. Most of what I'm going to be talking about today are vestibular pathologies and peripheral vertigo. And that's where you actually have a dysfunction in your inner ear. All right, so I want to orient everybody to what the vestibular system is. Now, this is somebody's right ear. This is where you stick your finger in your ear to pick all the earwax out, right? That little base at the bottom there is called your tympanic membrane. That's your eardrum. Now behind that you have 3 tiny little bones, your malleus, incus, and stapes, and they're designed to reverberate down through this little snail shell looking thing, and that's called your cochlea. And that's how you hear. For the rest of this lecture, I don't care about it. The only part that we're really going to be concerned about is all this stuff above here, this weird little alien 3 canal thing. Now it's comprised of 2 particular parts. It's comprised of a bony labyrinth and a membranous labyrinth. You can't really tell because they cut it all out so you could see it. But your vestibular system, the yellow part right here, that's actually called your membranous labyrinth. And it's a very thin membrane. That is completely encased in bone. And there's different sodium-potassium balances between the outer membrane and the inner membrane that can cause, if that delicate balance gets thrown off even by a little bit, that can be a cause of vertigo. Now, another important thing to look at right here is this output hole. That's called your eustachian tube. Your eustachian tube is where you drain waste out of your vestibular system. And that's going to be important in just a minute. So, how does all that come together? Well, we have 3 ways that we maintain our balance. 80% of our balance comes from our visual system. I bet you all know this, right? A little bit harder to walk around in the middle of the night than it is right now, right? Yeah, that darkness falls in and you start having to rely on the other 2 sources that give you your balance. So, visual system's pretty self-explanatory. Your proprioceptive system, this kind of puts it into touch, but I like to get a little more specific than that. You have Golgi tendon organs, which are in your joints, and that's what kind of the doctor's sort of testing when he hits you with the hammer, okay? You also have muscle spindles, and they're going between each individual muscle fiber throughout your entire body. Now, I'm going to give you all a real quick test on proprioception. I want everybody to close your eyes and touch your nose. That's proprioception. That's all it is. The way that you're able to find your nose with your eyes closed is your body has, your receptors are giving a constant feedback to your brain about your body's position in space. And that's all proprioception is. Okay?
So when you don't hit your nose, you hit your, what does that mean?
It means your proprioception's off. Or you've been drinking too much. I don't know. Kind of 50-50. All right, and then vestibular system. The vestibular gives us our equilibrium. It gives us spatial awareness. It tells us how quick we're rotating, and it tells us how fast we're accelerating or decelerating. Okay? The vestibular system's whole purpose in life is to tell your brain your head's position in space. Okay? Now, all of these input systems get integrated in the 3 parts of our brain. We have our brainstem, our cerebral cortex, which is the big brain, and our cerebellum, which is the tiny little brain underneath. You guys familiar with brain anatomy? Good, perfect. So, unfortunately, you guys actually know my dad, Greg. Those of you who know him will understand that his MRI was a little weird because it was actually half the size of most people's.
You're out of the wheel.
Oh, I've been out for years.
You need a spanking.
All right, so your big brain and little brain are in constant communication with your brainstem. They're constantly talking back and forth. The big brain, which is the cerebral cortex, that's your higher level of thinking. Your little brain, which is your cerebellum, coordinates all movement, and that's where your body display is housed. So if you have a problem with your cerebellum, you end up getting really shaky movements. You don't really know where you are. You can't fractionate your movement. You go to grab a glass and you actually knock it off the table. And we treat conditions like that. The problem is in communication. You can't fractionate your movement. You can't figure out where you are in space. And then the brainstem is integrating all of that. It's a constant highway up and down, and it's really fine-tuning every movement that you do. So, you have sensory input. Everything comes in. And then it gets processed. Big brain, little brain, and brainstem. And then you have output. Now, output goes into motor impulses, which control the eye movements, which is how all of you guys are able to follow me around. All right? You have your vestibular ocular reflex, which is how all of you can look at somebody and nod yes. I'm going to be getting into that later. And then you have motor impulses, which are postural adjustments. And that's where you go to step on something that's a little uneven, and you fall and you kind of catch yourself. That's all that integrating. It's all happening constantly. You're getting this constant firing back and forth, and that leads to balance. Now, this is just an easier way of discussing everything that I just said, because everything that I kind of went through, it's a little heavy. So it's a little easier to look at it this way. Everything starts with the car up at the top. It then drives down through your visual, auditory system. You come up with a motor plan, and you move. That's basically what happens. But remember, all roads aren't one way. So you also have sensory input coming up these exact same roads. And that's where you're getting your proprioception. You're getting info from your muscles and tendons and joints. And it all leads to things like hand-eye coordination. How you're actually able to look at an object as you're moving, find the object, and pick it up. Okay? So, clear as mud? All right. So, all of that was really just to give you a very brief overview of how we actually stand upright and don't fall down on a So, these are all the different kinds of vestibular dysfunction you can have. You can have unilateral vestibular loss, and that can cause decreased VOR. Now you're trying to look at me and you shake your head, your eye can't stay focused on me, it starts moving around. Guess what that makes you? Dizzy, right? It can cause disequilibrium, motion sensitivity, and head movements that can cause gait ataxia. Because you can't fix on an object and you turn your head, you end up kind of falling to that side. All right? Bilateral vestibular loss. This is more of the pathological stuff that I was talking about. That's ototoxicity, where all those tiny little calcium stones, they get eradicated. They're gone. You can't figure out acceleration anymore. You have no idea how fast you're going. The problem with bilateral vestibular loss, the way that we treat it, is we usually have to teach compensatory strategies. We can't fix it. We just have to teach you how to live with it, how to deal with it, and how to anticipate it. Okay? You can have a perilymphatic fistula. That's a hole in it. That's real bad. Remember that delicate sodium-potassium balance? Well, now it's all equal. It's all mixed together. You cough, increases pressure, stuff blows out of the hole, you fall down. Yeah, it's really insane. You can also have tumors inside your inner ear. A lot of this stuff ends up being diagnosed by an ear, nose, and throat doctor. A lot of the ways that I actually see patients, they're either going to be a direct referral or they're a referral from an ear, nose, and throat doctor who has already examined you, put you through a whole bunch of tests to make sure it's nothing sinister, like a tumor or like a perilymphatic fistula, and then you come to me to fix the loss of balance. Okay?
You can do that.
Absolutely. It's all up front. Absolutely. Meniere's disease is another real common one, okay? So this is an actual decreased absorption of the endolymph, which is one of the fluids inside your inner ear. If it has decreased absorption, it causes inner ear inflammation, which can also throw you off. Now, the treatment for Meniere's, the diagnosis of it is really an elimination thing. Well, we can't figure out what's wrong with you, so let's put you on a ridiculously low-salt diet and see if that helps. That's basically what Meniere's is. It's the only real way to treat it. And then the big one, benign paroxysmal positional vertigo. We're going to go into that later. I really want to talk about neuronitis and labyrinthitis. Neuronitis and labyrinthitis, I see a lot of patients that have had this in the spring and fall. Okay? Don't worry about the top part. That's just more sciencey stuff. The big deal is it can come from a backup in your sinus cavity. Now, reaching back to the first part a little bit. You remember that eustachian tube I talked about? It drains into your sinus cavity. What happens a lot in the spring and fall? Start getting backed up, right? Nobody likes being backed up. So, start doing this a lot. It ain't draining anymore. That causes inflammation within your inner ear. It can also be a bacterial or viral infection, which causes inflammation of the inner ear. Now, the way that that works is during the infection, your brain actually shuts down input from the system. So it doesn't even accept it for 24 to 48 hours. It can be pretty bad. A lot of people can be nauseous, they can even vomit, they can't really keep their balance. But that usually goes away. Most severe cases last about a week. Now, here's how I like to describe how labyrinthitis and neuronitis work. How many of you guys fall asleep with the TV on? Good many of you, right? Dark room, TV, doesn't hurt your eyes at all, right? Now, how many of you wake up at 2 a.m. in the morning to pee again? Right? Now, you can't really get back to sleep, so you decide to turn the TV on. Hurt your eyes right away, right? Like, oh, well, the TV didn't get any brighter, guys. We got oriented to the dark. That's exactly what happens to your brain. When you're having an inner ear infection, your brain shuts it down. It's like turns everything off. As soon as the infection's gone, your vestibular system starts sending those signals back to your brain. It's like turning that TV back on in the middle of the night. It can be a little overwhelming. Now, most people then adapt, right? You blink a couple times hard, you look away, and then your eyes eventually adapt to the TV and you can watch it, right? The problem is if you can't. And that is where we come into play with vestibular rehabilitation. So I'd just like to follow up from the lecture done yesterday for the Lake of the Woods AARP group because aesthetics weren't exactly there. I want to do a better video of the self-treatment for right-sided benign paroxysmal positional vertigo, or BPPV. So again, I have the lovely Jen assisting me out, and we are assuming that she has right-sided BPPV, and this is how you would treat it at home. So, Jen, if you wouldn't mind swinging your legs around to the right. You want to stay sitting in an upright position, and if you do believe that your vertigo is happening in the right ear, then you want to make sure that when you lay down, you have open space on the left side. If it is happening on the left, you just want to do everything that I say in reverse. So, Jen, if you wouldn't mind turning your head 45 degrees to the right, and then just lay right back over top of the pillow. Now, as you can see from here, the pillow is coming straight across her shoulders, allowing her head to go into a little bit of extension. And this is required to make sure that those crystals come off of that cupula or inside the crista itself and just fall into the canal, so that when we go through the rest of the repositioning maneuver, the crystals are allowed to flow through the entire part of that posterior semicircular canal and back into the macule where they can get reabsorbed by the body. So again, if you do experience dizziness here, you want to wait for that dizziness to go away and then add 30 seconds. Once that has happened, you turn your head 90 degrees to the left so that you're at a 45-degree angle to the left. You wait for any dizziness to go away and then add 30 seconds. From here, you want to keep your chin kind of tucked in towards your left shoulder. You're going to log roll over onto your left side so that you're kind of looking down towards the floor. Again, wait for any dizziness that comes on to go away, and then add 30 seconds. From here, you're going to kick your legs off the side of the couch, bed, whatever you're laying on, sit straight up, and once you sit straight up, you can look forward. From this position, you want to wait for any dizziness to go away, and then add at least a minute, if not 2. And that's the appropriate way to do the home exercise program for BPPV on the right side.